Thank you very much, Simon. I'm very honored to be coming to you today to speak to you all because I want to also learn from your experiences and what you have to say about this topic on housing modifications and disability. This is research that I started back when I was in the UK and at the University of Manchester, that I'm continuing here at the University of Hong Kong. And today's talk, I'll be talking about these topics on whether housing is ignored in a lot of research, especially research on healthy aging. Because I'm a sociologist, I'm very interested in conceptual models, theoretical models, especially on social determinants of health, because that is my background. So I'm very interested to see whether housing is adequately represented in these theories and concepts of social determinants of health. I'll be talking specifically about the role of disability, housing, and aging, using an empirical example on the effect of housing modifications on reducing disability outcomes. And I want to end the talk with some potential future directions. And it'd be wonderful if I could get some feedback from all of you about whether this research is interesting or important. So this is a slide that shows just how many hours we spend at home. So although this is data that comes from the United States, in many other countries, we find very similar patterns. So as people get older, we have here people aged 39 to 44 and upwards, you can see that the amount of time they spend at home increases a lot. So even the middle-aged people, say aged 40 to 44, they are spending almost 15 hours each day at home. And for the oldest people, 85 years and over, they're spending over 20 out of 24 hours at home. So if you think about that, that's a lot of time to be spending at home. And if we're thinking about things that can affect people's health and well-being, perhaps the number one social environment that we should be thinking about is people's homes. However, in a lot of literature on healthy aging, there isn't so much literature on housing. So in this slide, I just show you one example of the differences. So at the top over here, we have the number of studies I found on quick search in a database on neighborhoods and healthy aging. And here we find that there are 75 results. Okay. I'm sure there are many more studies, but in this very quick search, I found 75 results. But on the topic on housing and healthy aging, so that's the bottom of the slide, there are only about half of those results, 37 results. So you can see that neighborhoods and healthy aging is a much more popular topic than housing. This is a study that looked at different interventions that can be done to improve healthy aging. And the typical recommendations from a lot of the scientific literature is we should be more physically active, we should have better diets, we should reduce our alcohol, and we should not be smokers. So this is typical health behavioral interventions. And so there's recommendations for improving our life expectancy, our healthy life expectancy is to have some changes in our diet and our lifestyles, such as protein energy supplementation or physical exercise. You see over here, there's nothing about housing. So even though I showed that, for a lot of people, especially older people, most of their time is spent at home, there's nothing here about improving the housing. So let me look at some of the conceptual models on social determinants of health and to see where is the role of housing. This is a very famous model, conceptual model on the social determinants of health. It's called the rainbow model. So in the middle, you have the people, the individuals, their age, their sex, their compositional factors. And then as we go outside the circles, we see the wider social factors like their social and community networks, their living and working conditions that affect their health. And you can see I've circled on the bottom right housing. So housing in this conceptual model is one of the many things that affect people's health, such as healthcare services, water and sanitation, their work environments, their education. So this is a very popular model on social determinants of health. This is another popular model that also has housing that's listed in the neighborhoods and physical environments, along with transportation, safety, parks, playgrounds, walkability. So all of these are important factors for people's health and well-being. But I suppose for me, the role of housing is perhaps a little bit underplayed. So I'm just going back to the fact that most people spend their lives inside their house. So why is it that housing has such a small role in these conceptual models? If we go back to a very well-known model of our hierarchy of needs from Maslow, we see right at the bottom of this pyramid are our physiological needs, our need for food, water, warmth, and rest. And where do we get that? We get that from our homes, our houses. So housing is really at the bottom of our hierarchy of needs. Without that, we can't build on the other psychological or self-fulfillment needs. So one of the things that I found is that maybe housing is a little bit underplayed in these conceptual models of social determinants of health. And then I look at what the specific evidence is on conceptualizing housing hazards. So whenever I read epidemiological and public health literature on the role of housing, they emphasize lead poisoning, they emphasize how expensive the houses are, and they emphasize the risk of asthma because of poor ventilation or indoor allergies. But housing is much more than just lead poisoning exposure or how expensive the houses are. So in this example, we see over here a house with many risks of falling and the different areas in a house that are associated with falls, such as falls in the bedroom or in the stairs and hallways or in the bathrooms. And really, I want to say that housing-related factors are much broader than just exposure to lead or asthma. So, of course, there are negative physical health effects from toxins, poisons inside the house, such as damp and mold is also important. But then, of course, when we're talking about climate change nowadays, houses can be too hot. And also, in a lot of places around the world, they can be too cold, and that has a direct effect on people's health. Overcrowding is another big issue that can lead to poor health. In the previous slide, I showed that safety hazards is also an important consideration from housing-related hazards, and also the negative mental health effects that come from poor quality housing or noisy housing or insecure housing. So really, there are many, many more housing-related risk factors that we should be considering. And unfortunately, in a lot of the conceptual models, housing tends to be grouped with the neighborhood. So whenever people talk about housing, they say, oh, that's part of the neighborhood. But actually, neighborhoods are not the same thing as housing. So a lot of the interventions that have been done in public health on improving neighborhood effects in health, so they talk about making public transport more available to reduce obesity. They talk about the location of fast food restaurants that can be a risk factor for obesity, and the importance of proximity to green spaces, such as parks. That's important for people's physical activity. However, for a lot of people, just because there are green spaces and parks, or just because there is public transport, that doesn't mean that the parks or the public transports are accessible. So that's a very important feature that tends to be neglected in a lot of the public health literature on neighborhood effects. There are measures of distance of people's homes to parks or people's homes to the bus stop, but there are no measures on how accessible those bus stops, those buses, or the parks are. And finally, on this slide on limitations on existing concepts of housing in relation to aging studies, I want to emphasize the conceptualization of disability. So I'm back to this conceptual model on the social determinants of health. A lot of it makes sense. I don't disagree with a lot of these factors that have been identified. But for me, it's a very static picture. It's a snapshot. It doesn't say anything about the life course. So the emphasis here is on prevention of future ill health. But we know that a lot of people, as they get older, they will have some disabilities, some sort of impairments, physical impairments. And this kind of model doesn't help us in knowing what to do, what to intervene, what to change when people get older and become more physically disabled. We know that disability rises with age. That's not surprising. And actually, the biggest component of disability among older adults is mobility impairments. Yeah? So people become more restricted in their ability to move around as they get older. And this is data from Canada, but it's a very similar picture from different countries around the world. So there are two dominant models that are used in models of disability that have been used in the literature: the social model of disability and the medical model of disability. So the social model of disability is one that argues that people are not disabled, but actually disability arises because of the barriers that are put in by the wider social environments, because people are living in badly designed buildings or buildings without any lifts, or people are living in homes with inaccessible transport or inaccessible public venues. So the argument here is that society causes the disability, and that's very different from the medical model, which argues that people are disabled by the medical conditions. So it's the fact that people are disabled because they have a functional impairment, because they cannot see, they cannot walk, rather than putting the emphasis on the wider social environment causing the disability. There have been attempts to try and merge these two models. So the WHO International Classification of Functioning is one attempt that says, well, yes, it is important to consider impairments in bodily function and structures, but also it's important to consider the fact of social environments being a barrier to people's ability to participate in society. This is just some pictures that I took from Google Images of disabled people who are trapped in their own homes. And this is actually in Western context, in Western societies, becoming quite a big feature, because many people are people with mobility impairments cannot access their outside of their own home. They cannot even go outside their own home. So I remember when my father was becoming more and more ill, partly because of his health conditions, but also because of his disability, the area where he could move shrunk a lot. So it became very hard for him to go down the stairs. So he no longer ventured outside the home. Then he no longer sort of ventured to other parts of the house. And then eventually he no longer ventured outside his own bedroom or outside his own bed. So people become increasingly trapped in their in the spaces where they live in, partly because of their disability. And what I want to emphasize here is this notion of housing that traps people with disabilities is something that is not really covered in a lot of the conceptual models on housing as a health risk. So in this figure of housing-related factors, you see nothing over here about how housing itself could trap disabled peoples in their own homes, in their own beds. So I really want to talk about how housing and disability and aging are really very closely related. Now, the next few slides are data that come from England and the United Kingdom. So that's where I did a lot of my earlier research. And this shows how in England, the number of older people who rent their homes has been increasing a lot. And this is quite surprising when I talk to a lot of British people and English people. They say they have this image that a lot of older people, they own their own home. But actually nowadays that is changing because a lot of older people are renting their home. They don't own their home. And many of those people are living in homes that are not adapted to their disabilities. So, for example, we see that they don't have a level pathway into their own home, there's no, the threshold for entering their home has a barrier. The doorways are not wide enough to accommodate their wheelchairs, and the toilets and bathrooms are not on the ground floor. So less than 10% of homes in England have these accessibility features for people with disabilities. And there's a website in the UK called Infuriating Ramps. And it's funny, but it's not funny. I mean, so on the left-hand side here, you can see a ramp going up, but it's so steep. There's wheelchair people on wheelchairs cannot go up that ramp. Or on the right-hand side, you have a different kind of ramp. It's maybe less steep, but you can see it doesn't go all the way up. It just goes up to below the top stair. So even though people, there are these ramps that are put in that are supposed to be helping some disabled people, in practice, they're not really helpful at all. So I want to talk a bit about my research that me and my colleague Patrick Ruxell published last year on housing modifications and disability. And a lot of this research was driven by the relative lack of research on housing interventions and disability outcomes. So that's what I spent the first bit of my talk trying to convince you that actually housing is really an underdeveloped concept in health research, and a lot of reviews on healthy aging interventions, they focus on diet and exercise, but not on housing, which doesn't make sense at all because most older people, they live at home rather than they live they go outside to the shops or to the parks. And most of the existing studies are concerned with falls or preventing falls, rather than looking at other kinds of outcomes for people with disabilities, such as their depression levels, their social participation. And the other thing is that most intervention studies, they sort of combine different interventions. There might be a housing modification intervention that is combined with exercise therapy. So it's really hard to disentangle the effect of one intervention like housing from another intervention like exercise. And unfortunately, there's a lot of poor quality evidence also coming in the research. So in this particular study, we looked at mobility impairments because that's the most prevalent form of disability amongst older adults, especially living in the UK. And the housing modifications we looked at were structural changes in the indoor and immediate outdoor environments. So external housing modifications was something that I was really interested in, because of course, to go outside your home is a necessary thing if you want to have a social life, if people want to be independent. So both internal to the house modifications as well as external to the house modifications. This is an example of a randomized control trial that looks at housing as well as other interventions to reduce falls amongst older people. You can see over here that in red, that adaptations to the homes is one of many interventions that are proposed along with walking aids, alarm systems, other aids for personal care, and caregiver training. So all of these interventions are important, but as I said, it's very hard to then tease apart the effect of a single intervention such as housing. And the other problem with these kinds of research is that it uses the medical model. So it only looks at people who already have a disability or impairment. So it doesn't look at the wider group of people who could be prevented from falling and then acquiring a disability. So the typical example over here is that in a randomized control trial, in an experiment, you can propose a housing modification, maybe put in a ramp or some bathroom rails to prevent people from falling down. So hopefully there's a negative effect so that from the modification, the falls are reduced. We have lower number of falls. But of course, that is done only on people who already have a disability. Most of the times, we want to infer to the wider population of people who don't have a disability. And for that, we have to use a lot of observational studies. And we have this problem over here because the people that tend to get the housing modifications are already at risk of having a fall. So if you think about it, why do people put in a bathroom rail? They put in a bathroom rail because they're worried that they might fall down. So you have a positive effect of the disability conditions, like the risk of falling down. And then hopefully putting in the housing modification leads to a reduction in falls. But you can see over here, it's confusing because on the left-hand arrow, it's a plus sign, and on the right-hand arrow, it's a minus sign. So very often when you do these kinds of analyses in observational studies, you actually end up with a positive correlation between housing modifications and falls. So it looks like putting in housing modifications increases the risk of falls. So it looks like a bad thing. Maybe you shouldn't put in housing modifications because it will increase the risk of people falling. And that's exactly what has been reported in other studies. So on the left-hand side over here, this was a report done in Wales, in the United Kingdom, that looked at people who underwent a housing repair program. And actually, the people on the left-hand side who were frail but relatively fit, and who underwent the housing program, they actually had an increased risk in their risk of not being able to participate in society and not moving into a care home compared to the people who didn't get the housing program. So a lot of these very results that are surprising arise because of this very different effects that you have from the selection of people into these housing programs. So what we wanted to do was to sort of disentangle this into different components. And so we followed up people for about 11 years, about 12,000 people followed up for a long time. We looked at a range of health outcomes like falls, pain, and poor health. And we looked at particularly differences between external and internal modifications. So external modifications are those widened doorways, putting in ramps, automatic doors, and parking and lift modifications. And internal modifications are putting in handrails or bathroom or kitchen modifications. And basically what we found is that, I'll just skip over all of these pictures, but what we found is that among people who had mobility impairments, putting in external housing modifications reduced the risk of falls by 3%, reduced the risk of pain by 6%, and reduced poor self-rated health by 4%, the lack of social activities by 6%, and moving home by 4%. So these are absolute differences, not relative differences. So it doesn't sound very big, but in absolute terms, it's actually quite large. So there's a consistent evidence that housing modifications can prevent disability outcomes, a range of disability outcomes, at least from the English evidence. So in the last few minutes, I just want to talk about future research plans, especially about housing and disability research in Hong Kong. So with Simon, we have put in a research funding proposal. Unfortunately, it didn't get funded, but hopefully we're allowed to resubmit. So hopefully we'll get funded again. It's partly to look at this question in Hong Kong, but also in other countries. And one of the comments that we got back from the reviewers was that housing modifications is not important in Hong Kong. That worried me. So housing modifications is not important in Hong Kong because most people don't live in houses. And so I mean, maybe the reviewer didn't read very carefully. Maybe it was, they thought housing modifications only for houses, but of course, housing modifications is for flats as well, apartments. You can have modifications in the bathroom, in the kitchen. That's also in flats. So next time around, we will make that very, very clear in the proposal. And what we want to do is to analyze the experiences of disabled adults living in housing-related problems of housing in public sector rental. So I'm very interested in seeing the public sector rental experience of disabled people in Hong Kong, especially because in the UK, in England, the public sector experience of disabled people may not be so good. I have a feeling that maybe in the public sector, the response to housing modifications is a bit better. So I want to do some comparative research with disabled adults in public sector rentals in England and in Hong Kong. And I also want to use some very large databases. So I mentioned the English study, but that's part of many other studies from the Global Aging Database that includes studies from China, from Europe, from USA. So, and they do collect these kinds of housing modifications problems. And I also want to have more stronger evidence for the effect of housing modifications. So I'll be looking at effects from changes in housing that arise from people's partners' disabilities and on your own future disabilities. So it's these kinds of dyadic models where we're considering all the household members and their disability. So thank you very much for listening so patiently. I want to thank Simon for inviting me and all, and my funders and my co-authors as well. Thank you.